Hello everyone. Today I will discuss another developmental disturbances affecting the salivary gland, that is xerostomia or dry mouth. So coming to introduction, xerostomia refers to a subjective sensation of a dry mouth. That means the mouth or the oral mucosa becomes dry. Xerostomia, it is not a disease. It can be a symptom of certain diseases. It can produce serious negative effects on the patient's quality of life, affecting dietary habits, nutritional status, speech, taste, tolerance to dental prosthesis, and increased susceptibility to dental caries. Next is the etiology or the causative factor. What are the causative factors for xerostomia or dry mouth? It can be broadly classified into temporary causes and permanent causes. In temporary, it can be due to psychological factor, duct calculus or stone in the duct, CL adenitis, any drug therapy or any medication. In permanent etiological factors include salivary gland aplasia, that is completely absence or missing of salivary gland. Then Sjogren's syndrome, other systemic disorders, radiotherapy, any radiation, or surgical desalivation. So I'll discuss all the etiological factors one by one. The first temporary cause, that is the psychological factor. Anxiety and depression are well recognized as the etiological factor of reduced salivary flow. However, these psychological problems are often treated with drugs which may be the salivary inhibitors. These psychological factors most commonly seen in student or teenagers due to some peer pressure or some exam point of view. Next or second temporary cause, that is duct calculus, that is stone in the salivary gland duct. A blockage of the duct of a major salivary gland, most commonly the submandibular gland, it can produce dryness on the affected site together with pain and swelling in the gland, especially on stimulation. If this duct calculus is untreated, if it is not removed, then there is a obstruction that may lead to progressive fibrosis of the affected gland and permanent xerostomia. Next cause is CL adenitis, that is the inflammation of the salivary gland. It can cause reduced secretion because of acute infections include mumps and post-operative parotitis, while chronic infections or chronic conditions include swellings related to nutritional deficiency and hypersensitivity to iodine. Drug therapy. A wide variety of drugs may cause xerostomia. For example, anticholinergic and sympathomimetic agents may be implicated, and this group includes tricyclic antidepressant, bronchodilators, and antihistamines. In drug therapy, diuretics that produced by drugs and alcohol can result in dehydration and xerostomia. Zyvan, that is a newly introduced drug to aid smoking cessation, and that can also cause xerostomia. After temporary causes, next is permanent cause. First is salivary gland aplasia, that is a congenital absence of one or more of the major salivary gland because of the missing or absence of salivary gland, there is deficiency in salivary flow, and that can cause xerostomia. Next is Sjogren's syndrome. This combination of dry mouth, dry eyes, and often rheumatoid arthritis mainly affects women over 40 years of age and is often accompanied by mild fever. Other systemic disorders, xerostomia is associated with diabetes mellitus, probably a consequence of polyuria, as well as Parkinson's disease, cystic fibrosis, and sarcoidosis. It has been reported in cases of vitamin A, riboflavin, and nicotinic acid deficiencies and anemia that can also lead to xerostomia. Next, permanent cause, that is radiotherapy. The effect on the glands of the irradiated site is often rapid and profound. Post-radiation glandular atrophy is partly due to a reduction in the vascularity of the gland and partly due to the direct effect of the X-rays on the highly specialized and sensitive secretory epithelial cells. Because of the radiation, there is decrease in the vascularity of the gland, or because of the radiation, there is directly it affects the secretory epithelial cells. So the salivary flow is reduced and decrease in saliva that leads to xerostomia or dry mouth. Next is surgical desalivation. Surgery or physical trauma to the salivary gland duct that may result in damage to the gland, salivary duct, blood or nerve supply, and it impaired the salivary secretion. Then coming to clinical features, it is important to establish whether the dryness is continual or intermittent, whether it is accompanied by pain or swelling, or it can be unilateral or bilateral. Whether there is any relevant history of anxiety, stress or depression, a systemic disorder or any irradiation, trauma, surgery or medication. This history has to be taken. Then patient occupation, patient's diet and domestic situation often relevant. If there is an unilateral dryness with pain or discomfort and swelling in the affected gland on stimulation, that is an indication of a duct calculus or stone in the salivary gland duct. If it is bilateral swelling, then it may be due to Sjogren's syndrome. So examination of the patient typically demonstrate a reduction in salivary secretions and the residual saliva appears either foamy or thick and ropey. In the clinical picture in the diagram, you see the saliva is ropey, it is not flowy. It is thick and ropey saliva in patients with xerostomia. The mucosa or the oral mucosa appears dry and the clinician may notice that the examining globes stick to the mucosal surface because of the dryness of the mucosa. The dorsal surface of the tongue often fissured with atrophy of the filiform papillae. The patient may complain of difficulty with mastication and swallowing and even indicate that food adheres to the oral membranes during eating. The clinical findings doesn't always correspond to the patient's symptoms. Some patients who complain of dry mouth may have adequate salivary flow and oral moistness. Conversely, some patients who clinically appear to have a dry mouth have no symptom or no complaints. So there is an increased prevalence of oral candidiasis in patients with xerostomia because of the reduction in the cleansing and antimicrobial activity which is normally provided by saliva. In addition, these patients are more prone to dental decay, especially cervical and root caries. This problem has been associated with radiation therapy, and sometimes it is known as radiation-induced dental caries, but more appropriately it should be called as xerostomia related to dental caries. Then the treatment plan of xerostomia. The basic principles of management are first to eliminate or to address any etiological factors like drug or medication, calculus, and emotional problems. It is also advisable to promote salivary stimulation by using sugar-free chewing gum, which is effective and convenient. Regular review to monitor the condition of teeth, gingiva, and mucosa, and to give support and reinforcement or to preventive measures is advised. Then systemic pilocarpine is a parasympathetic agonist. Our doses of 5 to 10 mg 3 to 4 times daily. It can be an effective promoter of salivary secretion. Another one is cebumeline hydrochloride. It is an acetylcholine derivative which is approved by the US Food and Drug Administration for use as a sialogogue. Both of these drugs are contraindicated in patients with narrow angle glaucoma. So because of the increased potential for dental caries in patients with xerostomia, frequent dental visits are recommended. Office and daily home fluoride applications can be used to prevent decay, and chlorhexidine mouth rinse minimizes the plaque buildup. So these are all about xerostomia. What are the etiological factors, what are the clinical features, and what are the treatment plan for xerostomia. I hope you like this video. Thank you.